will be recorded and then will be shared out after. So I'll let the facilitators introduce themselves.
Hello and welcome. My name is Suzanne and I am one of the doctors that carry out functional assessments in the role of the Armed Forces Compensation Scheme. I used to work in the Centre of Health and Disability as well, and again that was a functional assessment role, so I'm very knowledgeable on both of the schemes, and I'm here to talk about the functional assessment role. We've also got Sathya.
Hello everyone, good afternoon. My name is Sathya. So I'm also one of the doctors that works currently for the Centre for Health and Disability Assessments, or the Health Advisory Service. So we are another business that are providing functional assessment advice to the DWP. Nice to meet you all.
And we've also got Sue. Oh, sorry. Yeah, Sue. Sue, you're on mute.
There we go.
I'm not great on, I'm better on Zoom. My name is Sue Godby. I'm an occupational therapist by background. I've always worked in vocational rehab and occupational health. Initially, I worked in the NHS and then within an insurance company. And for the last 10 years or so, I've worked in independent practice in occupational health and voc rehab. That's me.
Great. So that is us as a team. And if we're ready to share the slides. So as a collective, you've heard that we're from different specific areas that carry out functional assessment. And we have, as a collective, we're known as the Specialist Interest Group for Disability and Functional Assessment Medicine under the Supporting Occupational Health and Wellbeing Professions. And we're obviously going to talk about each of the roles within a functional assessment and explain what functional assessment actually is. But we're not going to specifically talk about what we do individually as such. We will give you an overview of that, however, but we are coming as a collective under the Society of Occupational Medicine and Functional Assessment Medicine. Next slide. So we are a group of healthcare professionals that practice disability/functional assessment medicine in a variety of different settings. So that could be for benefits assessment, vocational rehabilitation, fitness to drive, insurance, and much, much more. We are a group of doctors, physiotherapists, occupational therapists, paramedics, nurses from a multitude of different backgrounds, as well as pharmacists and clinical psychologists. So we have a wealth of knowledge between us all with regards to functional assessments and our medical knowledge. There's over 2,000 health professionals in the UK working in this field, and we're always welcoming new members to the group. We're also fully registered with the relevant governing bodies, and have to obviously maintain our CPD portfolio, and we have to have no restrictions to our practice, and for doctors we need a license to practice as well to carry out these assessments. We used to be known as social security medicine in Europe, but it is becoming more of a kind of term used as functional assessment medicine that we're using nowadays. What we're going to do is we're going to share what we do and possibly discuss how some of our skills might be useful in other settings. We are also here as members of the Society of Occupational Medicine, as I said before, rather than specifically our areas of where we work, but also we are here to kind of raise a portfolio and profile of what we do day to day and our areas of practice. Next slide. So, functional assessment. Does anybody know what disability assessment medicine is? Has anyone ever heard of it, come across it? What do you know about it? No? Anyone ever heard of it? Or have you had heard any rumours or any myths? No? Well, what do you think it is? If somebody said to you, oh, I'm going to see someone about functional assessment, what do you think that means? Anyone want to hazard a guess? Yeah, Pauline?
I think someone's going to be observed in a task and given feedback on their performance.
So, kind of, in some respects, there is an observational aspect to our assessments, yep, and examination is carried out. So, yeah, there is that component. But certainly what we do is we take a holistic approach to someone's ability to function, and we generally use function as a day-to-day, so what people can do day-to-day due to their medical conditions. Now, quite a lot of people have maybe one medical condition that impairs their ability to do certain things. So you may, for instance, have, if you broke your leg, you're not able to go running because you've got a plaster cast on, you're having to use crutches and it's painful. So functionally, you're not able to run or able to walk particular distances because you're using crutches. So functionally, you are limited due to that illness. However, you might end up having some other conditions, such as you break your leg, fair enough, but you might also have some, asthma, and your asthma might be pretty bad because it's winter and you've got an exacerbation of your asthma. That then may limit your ability to use your crutches as well, might limit your ability to use a wheelchair for your, ankle fracture that you've got that you're not able to mobilize. So then we take into consideration all the medical conditions and look at that and the ability for that impact and the functional impact that will have on someone's day-to-day activities. Therefore, they may need help. They might not be able to go to the shops. They might not be able to go to appointments by themselves. They might need transport. So these are things that we look at as an individual. We look at all their conditions and see how they interact with each other and affect their function, their day-to-day activities. So certainly you may have heard that there might be myths as to oh, well, somebody goes for a benefits assessment, it's because our job is to prove them wrong by doing these examinations and assessments. That's not the case at all. What we need to do is we get the information from the client, the patient, find out how their conditions affect them day to day. We ask their GP for medical information with regards to their condition. Is it a short-lived condition? Is it a long life condition? How does that affect them? Sometimes as a GP, you don't know these things because it's a question as when I was a GP, I didn't ask anybody, oh, how far can you walk or what can you do? It wasn't a question that I would ask because I was more interested in trying to sort out their exacerbation of asthma, let alone deal with their ankle fracture and their ability to mobilize around their house. It wasn't something that I was automatically thinking about from a functional point of view. So that's where we come in, is we're independent in assessing someone's ability to function based on their medical conditions. It's a clinical role. You have to take a history. You have to do examinations. You have to look at observations as well. So it's all a clinical role that we're having to apply to do these assessments and review all the evidence and justify the reasons why someone may be functionally limited in their day-to-day activities. Next slide. So when we come to what is disability/functional assessment medicine, so concerned with individual function related to a medical condition. So that's kind of what I was saying there. So we're wanting to know, how does that person's asthma or COPD affect them in their day-to-day life? Do they have multi-morbidity or versus comorbidity? Now, you may have your COPD, your ankle fracture, and you may have anxiety and depression. You may go and see 3 different specialists for that, but each specialist will only deal with that particular condition that you're seeing. So your COPD will only be dealt with the respiratory team. They won't talk about your ankle fracture. They won't really talk about your mental health. because they're not dealing with that. They're trying to manage your respiratory condition. However, we need to look at that as a holistic approach and look at all of those conditions. We're not just focusing on one. We have to focus on them all and how that could potentially affect someone's mobility, someone's ability to interact with others. We need to look at that as a whole. And as I said, quite a lot of people can have multiple conditions, and we need to look at that. We need to assess that. How does that impact their function? Also with disability analysts, they are specialist practitioners in disability assessment. So yep, we've all been fully trained to carry out functional assessments. We all have the abilities to carry out a history. You know, we all know how to take a condition history. We all know how to take and do examinations. But it's what our job is to then put all that together and write a robust report and justify the outcomes. So we don't just take note of the diagnosis that they have. We also give some indication regarding possible physical or functional impact. But again, quite a lot of medical conditions might not have functional impact to their day-to-day life. Take high blood pressure, for instance. Is that generally going to stop someone from day-to-day activities? No, not really. Not unless they had the severe extreme of malignant hypertension where they can't see, they're dizzy, they're needing to go to the hospital. You know, these are things that we have to look at function and look at the severity of each condition. And not everyone with the same condition is going to be affected. And that's why we look at an individual and their functional ability from day to day and how that is impacted by these conditions. So again, it's a biopsychosocial model. Not everyone's going to be affected the same way with the same condition, and you have to find out, and it's more tailored to that person. We apply our own medical knowledge and judgment to these conditions and to the history that we've obtained, and whether what is being said is related to what we've visualized due to the examinations or the observed findings that we've noted during the assessment, and we put that against our medical knowledge and justify if what we have seen, observed and heard is clinically relevant and clinically correct to the conditions that someone has and they are reporting. Next slide. So generally what happens in a functional assessment. So I've kind of already touched upon this, but first of all, what happens is the claimant fills in a self-reporting questionnaire. So they fill in a questionnaire detailing information regarding their medical conditions and how they are affected by their medical conditions. So as I said, they might have your COPD. Functionally, they may say they are unable to walk certain distances. They maybe struggle with stairs. They also may be fine. As long as they take their inhalers, they could be absolutely fine and have no functional limitations due to their COPD. Similarly, with a broken ankle, obviously someone's going to be limited for a short period of time. That's not going to be long standing unless they have complex regional pain syndrome. Fracture that doesn't heal requires further surgical intervention. All these different components have to be taken into consideration. And again, you read what the client has stated and you look at that information and they will comment on their function and how they feel that they are affected in their questionnaire. We also have medical evidence. That may be that the client also supplies the hospital letters from their respiratory physician or their orthopedic consultant. They might have that in their report. But we also write out to the GP as well and get further medical information, whether that's at the time the same time as the questionnaire is received, or it could be that we're going for further medical evidence for a review. They may have been coming back for an assessment after a review period. So we might have to go out and get further medical evidence from the GP. And that's in the form of a form called a 113. And in that form, the GP normally fills out additional information. And they, again, talk about the conditions, the symptoms, the treatment that they've had. And on the back of the page of a 113, there's also information that asks, what is the functional limitations? And again, as a GP, when I filled in these forms, I had no idea what half these functional things meant. I didn't really know what personal action meant, or if they were talking about walking, I would say, yep, walks with a crutch or walks with a walking stick. Yep, that's because I've seen them walking when they've come to see me for their asthma review and they've got the broken leg. So I would write that in. But again, we're looking at it as a whole. So then once we've got all that information from the GP and the self-reporting questionnaire, we then have a gather of new evidence. So that is, we get the person in for their assessment. That can either be done by video assessment, telephone assessment, or a face-to-face assessment. And that is where we're getting the oral evidence. We're getting the evidence from the client. We're taking a condition history. We're listing what conditions they have, when it was diagnosed, what treatment they're on, how does it impact them from day to day. We're getting that information. We're then looking at informal observation. So, did they walk from the waiting room to the room with a crutch? Were they able to walk independently? Did they need support from someone else? And then when they're in the room, we also look at them being able to sit on the chairs, get up from the chair independently, get onto the examination couch. All these are observations that we carry out throughout all clinical examinations. Any clinical examination that's done, these are things that you're doing automatically anyway. Then when it comes to the clinical examination, yep, you're carrying out a full examination as you would normally in clinical medicine. You would be doing examination of joints depending on what it is. You would maybe need to do blood pressure checks. These are things that you would be expected to do in any other clinical role. So we would carry out clinical examinations. And then beyond that, once we've gathered all the information, we then compile available evidence. So we put together the report. So this is objective and impartial evidence that we've collected. We write an impartial report and put it all together and write out a justification as to how their function is affected by their medical conditions. And obviously my role as an assessor is different from previous therapeutic roles, as I am not aiming to treat their conditions. I am aiming to find out how their conditions affect their day-to-day life and overall their function. And that is my role with regards to that. I wouldn't provide any clinical advice during these sessions. If there was an abnormality found, there is processes in place in which we would then contact the GP and inform them of the abnormality that was found so that it can be looked at and processed further. Because as a functional assessor, we don't have the ability to refer to secondary care if need be from like a GP referral. We only have the ability to refer acutely to A&E if an acute, say, chest pain occurred, you would manage that acutely. Or if they had malignant hypertension that you noted, you would have to deal with that acutely. But we don't have the ability to follow up someone with ongoing care. So we do need to look into informing the GP if there's any abnormal findings that we've come across during that. But it is my responsibility to compile all the evidence that I've gathered, compile a biopsychosocial model, get the information with regards to function, and carry out a well-written, justified report. Next slide. So when we're looking at this information, as we've said already, we've got the claimant's questionnaire, they're self-reporting. We've got sometimes claimant diaries. We've also got medical evidence provided by consultant letters. They may have care plans, investigations, the outcomes of these, treatment summaries, discharge letters and discharge reports. As I said, there's specific information from the GP, which is in the form of a 113, which you can get on the link. We also sometimes ask for a GP factual report. Now that may be that we have a specific question that needs to be asked, and we'll write out to the GP and suggest, can you provide us some information on this particular condition? And that may be because the evidence that we've got doesn't provide us with information, or it may be that we just need to get further medical evidence with regards to certain conditions. So then with regards to that, we do telephone calls with health professionals as well involved in the customer's care, and this could also be to specialist nurses, consultants, physiotherapists, occupational therapists. It could be to the GP, it could be to the nurses, anyone that's involved in their care that we can contact and make get further information if required. We also have previous reports to look at. If somebody's been assessed previously, we have the information available to look back and see and compare the differences, their examination findings. Before, were they able to get on the couch independently to now? Has their condition worsened? Maybe they've got arthritis, and as time's gone on, the arthritis has got worse. And again, we would use that information to compare everything to write our own justification for our reports. Next slide. So what does useful evidence look like? So we've got some information here. Not the evidence that we need doesn't need to be exhaustive. You don't need to give us screeds and screeds of information. Just a small amount is needed. So history of anorexia nervosa, diagnosed 10 years ago, during brief admission, now stable, no outpatient follow-up, sees surgery, mental health nurse, periodically for review, and no medications. So that gives us an idea of what's going on. It's very short, very snappy, and it gives us a good idea of where they are with their anorexia. With regards to the back pain, being referred to physiotherapy, no x-rays performed, managed with paracetamol and naproxen. That's again quite a good snapshot of back pain. With regards to back pain, again, if you have someone who in their questionnaire has back pain, there's two people that could have the same back pain written on their questionnaire. But this one, like this person here, the back pain, referred to physio, no x-rays, managed with paracetamol and naproxen, might be one person. But you might have somebody who's got back pain because of a spinal injury. They might be in a wheelchair. They might be having multiple surgeries to their back. They might be also on paracetamol and naproxen because maybe they can't tolerate other medications. But they have lots of other things going on with their back pain. So although somebody has back pain, it doesn't necessarily mean those people are functionally impaired the same. So again, it's all about getting the level of detail that we're needed with regards to the condition and their day-to-day life. Again, with severe learning disability, lives in supported accommodation. That gives us an indication of what support they need. They need support with all activities of daily living. His care has to bring to appointments, so they're never on their own. They don't go out by themselves. Later social services review, letter attached. So again, this all indicates the severity of that individual and the outcome with regards to that. Again, another one, severe COPD, under specialist care, home nebulizers, waiting on oxygen therapy, unable to leave the second floor flat due to breathlessness, on the list for the GP home visits, and attached are consultant letters. And again, that's not extensive information there, but by reading that, you know that person's pretty severe with their COPD. You know, they're functionally, clearly that person's going to be functionally limited. They're only able to stay in their house. They need home visits. Okay, next one. No known suicidal ideations or thoughts of self-harm. Again, that's really useful to know. However, again, sometimes people may say that to the GP or to the nurse who they're seeing, but actually when they come for an assessment, that may change and they may have expressed thoughts of self-harm or thoughts of suicide. And with that, we need to take a detailed history of that information and obviously get consent for them to inform their GP of this information. And we need to act on suicidal thoughts or suicidal ideations if that does come up during an assessment. An appropriate action needs to be taken during that time. Okay, next question. So again, sectioned under the Mental Health Act, had admissions for assessments for 3 months ago, received extensive community mental health team input at home, known to have ongoing suicidal ideations. Now that's something that we already have the information for, and we can make a justification, an outcome based on that information. We can look at that information and apply that to our reports. So although these are really useful bits of information for all these different conditions, you can see there's not that much information that's written there, but each individual section gives a good account of what's going on in their day-to-day life. Next slide. So when we come to gathering new information, as I said, we do the oral evidence, which is your clinical history, your diagnosis. What actual diagnosis do you have? What medications are you on? Have you had any investigations for this condition, or was it diagnosed by the GP clinically? Or have you had x-rays? Have you had blood tests, scans? Have you ever had this before? What previous treatments have you had? What investigations have you had, and did it help? Did it not help? Have you had any changes in the presentation? Again, this is something that we all are always looking at, because if there is a change to the presentation, i.e. somebody may be having worsening chest pain, for instance, that's something that we need to act on as a clinician. We need to act on if people are becoming unwell, and we need to let their primary care provider know this as well. We look at the observations, the movements that are being made, how an individual engages, such as the level of breathlessness. Is there any swelling in joints? Maybe they've got increased or decreased muscle tone. Are they exhausted walking to the exam room? Also, you look for other objective signs, potentially, that they could be have blue lips, for instance. If they're COPD, they might be so breathless, they might have blue lips. Or they might be walking with a limp. They might be requiring support. All these things are observations that you make every single day, day to day. Then with regards to clinical examination, obviously if it's a mental health condition, we would do a mental state examination. And we'd record that in a detail in our reports. Cardiorespiratory examinations, sometimes even need to do spirometry in some assessments, depending on what assessment is being carried out. But these are things that we do. Musculoskeletal, we would be doing examinations of that. We do function versus anatomical range of movement. Now, for certain movements, you know, you don't have to have a full range of movement of the joint to be able to do certain tasks. Like for me to lift a spoon up to my mouth, I don't need my shoulder to be all the way up here and going round in circles. I just need the ability to put, you know, my shoulder up a little bit, my elbow up. So I don't need a full function, I don't need a full anatomical range of movement, but I do need a functional range of movement. And that's where the function comes into play, and how that is, if certain conditions will be affected or will affect the functional range of movement. Also, if there is no diagnosis made, unless in some specialist benefit cases we might make a diagnosis, but people could have symptoms but they don't have a diagnosis. That may be because they've not been investigated yet. It might be that the GP's not come to a conclusion yet. It might be that they've not mentioned it to their healthcare providers. And again, that's something that we would then need to take forward and bring to the attention of their healthcare provider. Grand, next slide. We also take what's called a typical day function, which is your functional history. And with that, we ask things like, what are you able to do? What can you do? Tell me about getting up in the morning. Do you have any handrails around your bed? Do you need support to get out of bed? Are you able to do it independently? Do you have to do it in stages? You want to be able to visualize their day-to-day activities, from getting up in the morning to going back to bed. What do you do next after you've got up? Do you have a shower? Is it a bath? Do you have adaptions in your bath and shower? Do you have aids in your bath and shower? You know, all these things we want to look at. How do you start your day? What happens next? After that, what do you do? In the kitchen, Do you need support in the kitchen? Perching stools? Do you have aides in the kitchen? Do you have someone to cook for you? Do you have some extra support? Home helps? How do you get your shopping? Do you go yourself? Do you drive? Do you walk? Do you get the bus? How do you get to the bus stop? How do you get from the transport to the shop? When you're in the shop, how do you pick up your items? Can you do it yourself? Do you need support? What about carrying your shopping home, putting your shopping away? All these things are day-to-day functions, which you don't automatically think that you do, but you need a certain amount of ability to do day-to-day tasks. And that's why we go and get this detailed history of the functional history of day-to-day activities. And it covers a whole range of different activities. Also, some people may be working. So again, you would want to take part of the occupational history. You'd want to take a functional component of that. What do you do in your work? What job is it that you do? What does that entail? Do you sit for your job? Do you walk around? Are you standing? What are you actually doing? So again, you take a functional aspect of that role as well. Grand. Next slide.
Thank you,
And that's
Suzanne.
me.
Thank you. So as Suzanne was saying, we've gathered all the evidence from the client. We've got some previous evidence to look at. We now need to go about compiling all of the available evidence and putting it together to make a report for whoever it is intended to. So we integrate information from lots of different places. As we've mentioned already, we can have GP letters, specialist reports, self-reported questionnaires from the clients, interviews with the patient themselves, obviously, during our assessment, plus any examination that we may have done with them, and also observation during that examination if it is a face-to-face or video assessment. We then need to arrive at our advice or output and tailor that to whoever it's intended to. Okay, so as you can see, point 2 at the sort of 2 or 3 o'clock on that clock is evaluating the symptom variability. This is really important because I'm sure, as you know, a patient coming in on one particular day may be exhibiting very different symptoms compared to the day before or the day after, depending on their condition. Our role as disability analysts is to make sure we are understanding the variability of their condition and how that affects their function day to day. So not just a snapshot of how they were on the assessment on that day, because that provides little use to the patient themselves and also to whoever our report is going to. What we really need to take into account is the variability of their symptoms. So often we will ask them, as Suzanne was talking about that typical day, we will ask them, all right, let's go through a good day for you. What sort of things are you able to do on your good day? And then tell me about a bad day. What can you do on a bad day? What can you not do on your bad day? And what's stopping you from doing that? And then we think about how often they're having good and bad days, the triggers to those good and bad days, how long maybe a bad period will last, whether that's to do with mental health or physical health, to come up with a real understanding of how that client is affected by their one or multiple medical conditions. It's important for conditions such as chronic fatigue syndrome, because the variability associated with that condition can make it quite hard for us to determine an overall assessment of impairment. So that's why it's really important for us to go into that detail with the client. We may also have information from the GP letters or specialist letters that detail about the variability in their symptoms as well, which is really, really helpful. Another example of variability would be post-exertional fatigue, for example, in something like chronic fatigue syndrome. So actually somebody may say, yeah, I can walk to the park 10 minutes away and back again. But then the key question is, and how do you feel afterwards? If it's then, well, that's me done for the rest of the day because I'm absolutely exhausted and fatigued, or my muscles are aching and I wouldn't be able to move off the sofa for the rest of the day, then that gives us a real understanding of the function of that client and how their pain or fatigue or whatever symptom it may be is affecting them. Because it's no good being able to walk to a park for 10 minutes once a day and then being able to do nothing else in their day. However, you may get some people that pace their activities. So they've been to chronic fatigue a pacing course, for example, or some CBT. So they understand their condition a lot better, and they may be pacing their activity during the day. So they may manage 10 to 15 minutes of a bit of light housework, then understand to stop before they get too exhausted, to have a rest for maybe half an hour, and then can continue with something else after that. Again, that gives us a really good understanding of the variability of their condition. Sometimes there are aspects of our evidence that we have that conflict. So sometimes we may have a questionnaire filled out by the client that reports they've got a severe functional impairment. They say, I can't do anything. And then when we see them in in assessment, they may have an apparently normal examination. No problems with any anatomical ranges of movements of their limbs. But what we have to remember there is that examination is likely just a snapshot of their function. And actually, we need to get a bit more detail from their history, understanding, well, what did it take for you to get here today? How are you going to be for the rest of the day or even the rest of the week? Because that one snapshot of a normal examination may lead us down a completely wrong path and a wrong outcome for the client. So that's why compiling all of the evidence that we have, using all of these bits that we have from specialists and medical professionals that are looking after the client, as well as our own assessment, makes the outcome of the report much more accurate for the patient. It's important, again, to think about the biopsychosocial model, as Suzanne mentioned briefly earlier. So two people with the exact same diagnosis, maybe they're on exactly the same medication and have the same input, may be experiencing their symptoms in very different ways. And that again means their function is very different. And that could be due to a number of reasons that are going on, whether it's financial issues or family issues, personal issues, their upbringing and how they've been brought about to think about, for example, pain or mental health and how they respond to that. All of these things, as you will all know, will affect how that person deals with their medical conditions. So this is also something that we need to think about. This is the reason why we are independent practitioners and we look at the client. We have the ability to look at a client as a whole, because we're not just looking at a diagnosis and a list of medications. We are able to look a bit deeper, to look into the functional aspect of how those conditions are affecting them. There may be potentially conflicting terms. So an example of this would be maybe a psychiatry outpatient letter that says client's got schizophrenia, but they are now stable and they've been on the same dose of medication for the last 3 years. The definition of stable to a psychiatrist is very different to the definition of stable that we would use in disability analysis. So that patient with schizophrenia may be stable in terms of their active psychotic symptoms are not getting any worse. They're still there. They're there every day. They experience paranoia, visual, auditory hallucinations, whatever it may be. However, they've been taking this medication for the last 3 years and they haven't got any worse. So that is stable in terms of secondary care and for the psychiatrist. However, in disability analyst medicine, we need to think about how those stable symptoms are affecting that patient's function day to day. So those ongoing active psychotic symptoms would be something that we need to dig a bit deeper into and find out how it's affecting their function. Are they still locking themselves away, avoiding any social contact with anyone, perhaps responding to their visual and auditory hallucinations in maybe an inappropriate manner? Those are the things that we need to think about. So we do need to address the inconsistencies that maybe a layperson would look at and be like, well, this person is stable, there's nothing wrong with them. We need to then address that to make sure that whoever's the recipient of our report understands what was meant by that and actually what is going on with the patient day to day. We then make recommendations to whoever we're writing the report to. So in my case personally, our reports are advice reports to the DWP. There are people at the DWP called decision makers. They are the ones that make the decision on particular benefit streams. And therefore, our reports need to be tailored towards somebody who is non-medical. So we would gather all of this medical evidence, gather all of this information from the client, and compile a report that can be understood by a non-medical professional. We often have to use particular definitions because they are in legislation as approved by the DWP. So our reports tend to be very specific. And again, as Suzanne mentioned, we are all trained in writing these reports very specifically to tailor them towards our advice towards the DWP. There is, as Suzanne's mentioned a couple of times already, there is an important point to remember. We are all still registered healthcare professionals. Okay, I work with physiotherapists and nurses. We've got Sue here, who's an occupational therapist. We all have our own professional governing body. Okay, and our first principle, of course, is to do no harm. So sometimes this means sharing the information that the patient has provided to us with other healthcare professionals to make sure that that patient is safe. Sometimes when a client comes to us, we have very limited information, possibly only a questionnaire that they filled out themselves, and we have no other medical evidence to corroborate or give us more information or detail on what's happening. So it's our job then to get as much information as we can out of the client that is relevant to whatever report we may be compiling for them. Obviously, it goes without saying, the patients are made to feel comfortable with the healthcare professional that they may be seeing. And we are very lucky that we tend to have a bit more time with the patient, sometimes up to an hour, talking on the phone, on a video assessment, face to face. And so sometimes certain areas that a client may not have divulged to their GP may come out in an assessment. In that case, we always ask the client, have you told whoever's treating you about this condition? If it's a no, we would then weigh up whether this is something that we do need to let the GP know about. Okay. In all instances, we would always say, we really suggest that you talk to your doctor about that, because that's something that they may be able to help you with. Again, we're not there to diagnose or treat the patient themselves. That's not our capacity. However, we can signpost them to wherever they need to go. Sometimes there are more serious things that a client may divulge to us that they haven't told their GP about, or maybe a mental health practitioner about, that we feel is really, really important that they do know. Okay, so whether it be some suicidal thoughts, plans, intent, self-harm, thoughts, plans, intent. These are specific questions that we are required to ask by the DWP in our reports, and therefore we tend to go into quite a lot of detail about them if the answer is yes to any of those questions. And if the answer is no, my GP doesn't know about it, or the psychiatrist, whoever, as Suzanne mentioned, there are processes in place in which we have to tell the GP in the client's best interest. We always ask the client for consent before we do that. However, if they don't give us consent, we would again weigh up the risks and benefits of not telling the GP and think about the client's best interest moving forward. We also have process for safeguarding. So we may not have the information that you have on your file about the client's sort of family situation, for example. But if we are worried about safeguarding, we have processes where we can escalate that and report that as well. As I said, we are all registered under our respective professional bodies. So we have the same standards of customer care that any clinical practitioner would have as well. Sometimes that may mean a call to you as GPs to say, I've had this client in with me today. They've let me know that they're having suicidal thoughts and have been for the last 3 months, or even more recent than that. And they've told me that they've got a plan, etc., etc. So therefore, I'm just handing that over to you, as that is something that you may want to be aware of. Depending on which provider is contacting you, it'll usually either be done by phone, or we will send a secure email with a form to let you know what's happening. And also it depends obviously on the urgency of that information. If at any point we think the client is at immediate danger, we will obviously be calling 999 or referring to A&E if we think that that's necessary. Okay. We do also have the ability to do welfare checks on clients. So we may ring them, if it's a telephone assessment, for example, we may ring them later on that day just to double check that everything's okay. And again, that would be something that's documented on their file as well. So just a bit of reflection for you all. Have you ever had one of these calls from one of us perhaps, or one of my colleagues? And did you have any concerns about it, or is there anything that you wanted to let us know that would make it more helpful to you when we call you? Or maybe you haven't had any calls from us. No? Okay. So just so you are aware, if you do get a call from one of us, that's the reason why we are calling you, to let you know. Okay. So there are a number of specialist fields within functional assessment medicine. As you can see here, it's pretty self-explanatory. So we've got the DVLA assessments, working out somebody's fitness to drive. We have benefits assessments, insurance assessments, vocational rehab, and also veterans assessments. I will confess to you, I am no expert on the DVLA fitness to drive assessments. I don't do them personally. However, it is part of our field. There is a link there that you can access if you want more information on it. But essentially, it's assessing somebody to see if they're eligible to drive. So it's assessing their ability to drive safely and their risk of a sudden or disabling event. So if they have a car license, I believe that's a category 1 license, if they have a car license, their risk of having a sudden or disabling event should be less than 20%. For obvious reasons, if somebody is driving a lorry or a bus, so a different category license, that risk of having a sudden or disabling event needs to be less than 2%. Okay. Drivers must not drive if their medical condition makes them unable to safely control a vehicle in whatever sense, or if they have a condition that is likely to cause a sudden disabling event. Okay. So I have a little case study for you, if you like, here. You can have a read of this and tell me whether you think this lady, it's a lady, isn't it? Yes, Mrs. Oh, sorry, I haven't even showed it to you. There you go. Tell me if you feel this lady would be fit to drive. So she fell off a ladder and hit her head 4 weeks ago. She lost consciousness for a few seconds, and the brain scan revealed a frontal contusion. She was discharged the next day with no symptoms. So she has a car driving license, Group 1. What do you think? It can be a show of hands, or if anyone wants to talk to me, I would be happy to receive anything. Lovely, thank you, Sarah. So no, because of the brain contusion. Does anyone else have any thoughts as whether this patient, Mrs. HI, would be fit to drive or not? Yes, if no ongoing symptoms. Okay, thank you, Abby. Anyone else have any thoughts at all? So the answer is that actually, because the traumatic brain injury increases the risk of having a seizure, she would require 6 months off from car driving. Okay. So it's that sudden disabling event that we need to think about there. And I guess a period of monitoring over the next 6 months to see how she's gone following her head injury, which was only 4 weeks ago. So there is a chance that there may be longer term consequences as a result of that. Okay. So I'll give you another case study here. So Mr. AD, age 63, he's been diagnosed with young onset dementia. He's a Group 2 driver, meaning lorries, buses. His employer arranged a risk assessment, driving a bus last week, and the report was very satisfactory. So the report came back with that Mr. AD passed with flying colours. So what are we thinking? Is Mr. AD fit to drive or not? Does anyone have any thoughts about that? Good question, Sarah. What happens if the route changes? Absolutely. I'm sure we've all been on a bus that's been diverted at some point. Anyone else have any thoughts on Mr. AD? Do we think he would be fit to drive? Emily, no, Group 2 driver with dementia diagnosis. Absolutely. So you'll remember from my previous slide, thank you, Natalia. So may be able to retain own car license, but bus, no, even with employer's risk assessment. Absolutely. So you may remember from the previous slide that margin for a risk of a sudden disabling event is a lot lower when you have a Group 2 license for obvious reasons. Okay. Oh, sorry. There we go, actually. So the dementia is considered a bar to Group 2 driving. Okay. Anyone have any questions on any of that at all? Okay. So this is the, again, apologies because I'm no expert on DVLA assessments, but this is the general sort of overview on what is looked at in a DVLA assessment. So there's driving mobility assessment centres and also self-declaration. So the driver themselves would declare to the DVLA that they're not fit to drive. There will be consultant reports or assessments, and possibly a GP report or assessment. And then there's a panel opinion. There may be different outcomes, as we have seen from those couple of short case studies, different outcomes based on which group license they hold. Okay. So I'm going to go on to functional assessments for benefits. This is something that I do as my bread and butter, and I've been working in this field for the past sort of 8+ years. There are lots of different types of benefits. You may have heard of some of them. You may not have heard of any of them, in fact. So this is just a very brief overview of the different types of benefits that we may see. So there is something called a situational related injury benefit. So this provides financial support or compensation where long-term ill health or disability is present due to an occurrence. So, for example, vaccine damage, or in Northern Ireland, there is a Troubles Permanent Disablement scheme as well. You may have heard of PIP, Personal Independence Payment, and Child Disability Living Allowance. PIP's been in the news quite a lot recently. So PIP is essentially financial help to help with the extra costs of living with a long-term ill health or disability. Okay, so again, as we've spoken to you before about the process of going through a functional assessment, the client would fill out possibly a self-reported questionnaire. We will have some extra evidence from other medical professionals, do a face-to-face or telephone or video assessment with them, and then provide a report to advise the DWP on their function against the DWP-based criteria. Okay. There are work-related or armed forces injury benefits. So you may have heard of something called an industrial injury benefit. So this is where there is financial help or compensation where there is a long-term ill health or disability as a result of an occupation-related injury. Okay, so if we think about something like noise-induced hearing loss for somebody that's been working in a very loud factory for a number of years. Again, there are quite strict criteria in which you may or may not be eligible for these types of benefits. And it's up to us as the healthcare professionals assessing these clients to get as much information as we can, particularly around their occupational history. How long had they been working in that very noisy environment? Were they provided with any safety equipment to minimize that risk? Because obviously there is law and legislation, the health and safety boards, that they must have safety equipment if it is a very over a certain amount of decibels for a particular amount of time. And then we will compile that again with information from an audiologist, any other specialists involved. Sometimes we do our own examinations to determine the level of hearing loss as well. We provide that, put that all into a report, and provide advice against the guidelines that the DWP have set up, which is legislation. And finally, this is one that you most likely would have heard of, Employment Support Allowance, ESA, or Universal Credit. So this is something that you may hear from your patients quite a lot. Maybe they come to you and ask you, could you write me a letter for ESA, Universal Credit? Essentially, it's financial support for somebody when they are unable to work because of a long-term ill health or disability. Okay, so this tends to be the bread and butter of what I do day to day. And again, the reason why we often get we often get patients come to say to us, well, I have a Med3, a fit note from my GP saying that I cannot work. It says I'm not fit for work. So why am I having to come to another assessment for that? My answer to that is that we are assessing the client's ability to do any type of work, not just their own occupation. Okay, so rightly, the GP would have signed the Med3 saying you are not fit to work as, for example, a builder because of your cruciate ligament injury. Correct. However, then the client comes to us, we have to assess their ability to do any type of work. So work sitting at a workstation, if they've got good upper limb function and no problems with their cognitive function, that may be suitable for them. All right, so we are assessing their ability and providing advice to the DWP based on the criteria that is legislation from the DWP. And that's why we get all of this information about their functional ability day to day. How is that cruciate problem affecting them day to day? It may mean that they can't walk to the local park and back anymore. However, they're okay driving short distances. They're okay sitting when they're watching telly or sitting at a computer, using a laptop. They can walk around their home, okay, with a crutch. So these are the things that we would take into account when we're thinking about somebody's functional assessment. Okay. So how does the process work? This is sort of an overview of the journey of what happens when a client applies for benefits. And I think this is really helpful to know, because if one of your patients comes to you and says, I'm at this point, or I've done this, I've had an assessment and I'm waiting for the outcome, or I've just filled out a questionnaire, you can kind of understand, okay, well, that's where they are in the assessment process. So the patient initially makes a claim through a form, usually either online or on paper, where they provide a functional and medical history along with any medical evidence that they may have available to them. Okay, it is made clear on the forms that they are given that there is no need for them to pay for any extra medical evidence that they want to provide. There's no need for them to do that. Okay. However, if they have their most recent clinic letter or a letter from their GP that they want to include in the evidence that they send in to the DWP, absolutely go for it, because that is really helpful to us as well. Okay. So they submit that claim form, and then the DWP refer to the appropriate assessment provider. So you may have seen a couple of these assessment provider names before. You may have not. Some of them are going to be changing over the next few months as well. So you may see a few new ones. Something like Independent Assessment Services, Capita, Maximus. The HCP, the healthcare professional that works for that particular assessment provider, will then review the paperwork that the client has sent in. Sometimes, if there's enough information in the questionnaire and in the information that the client has sent in with their questionnaire, it may mean that a report for advice can be made without seeing the client. Okay, so we've got enough information. We've got a questionnaire, for example, somebody with learning difficulties. The questionnaire has been filled out by their appointee because they've got severe learning difficulties and need 24-hour supervision. We have a recent clinic letter from the learning disabilities team that confirms everything that's been said in the questionnaire. We have a Med3, a GP fit note that confirms they have a severe learning disability. What more do we need to know? If everything is consistent, we can go ahead with just a paper-based assessment. So there's no point calling that client in and making them go through an assessment, which is largely unnecessary, because we've got all the information here to make our advice for the DWP. However, sometimes and the majority of the time, I would say, we don't have enough information to make that report for the DWP. So therefore, the client would be called in. Post-COVID, it can be a telephone assessment, a video assessment, and we still do face-to-face assessments. So much like the work that you guys are doing now, it's very much hybrid since COVID. Used to be all face-to-face. And we would call them in for the assessment and do all the history taking and clinical examination, etc., that we talked about earlier. We then put that together with the information that they've already sent us and possibly other things that they would have given us at the assessment as well to compile our report. If we're at the initial review stage by the HCP, this is when you may get a request for further information as a GP or a medical professional that is caring for that particular client. So we have some information from the client in their questionnaire, and we need a bit more confirmation from whoever's caring for them. So that is when we may send you a form such as something called a 113 that Suzanne talked about earlier. Or there's other forms called an FRR2. I have to say that very slowly because it's a bit of a tongue twister, that you may get that ask more specific questions rather than an overall view of their function. And if we receive that back, that information may allow us not to have to call the client in. So actually it's beneficial to the client if you do send us information that you think may be helpful. If we don't get any information back, it's likely that we're going to have to call the client in to assess them because we can't do it we can't make a report just based on the information that they've provided in the questionnaire. So that is that point, those bluish boxes, that is the point that you may be contacted by us just to provide a little bit more information. And as Suzanne shared earlier, that information does not need to be extensive. Okay, we're not expecting you to do a functional assessment on the client because we understand that that's not what you'll be doing day to day. You're there to treat the client and provide them with care. So just those small bullet points that either confirm or tell us a bit more information on what level of treatment they're having, what medications they're on, they've been referred to the secondary mental health care team, something like that, just gives us that information. And then we can use that either to say, okay, well, that confirms everything in the questionnaire, we don't need to call them in, or actually that's a good bit of information there, but actually I do still need to see them face to face or over the phone. As we said, the report is then based on the benefit criteria that is set out by the DWP. It is legislation, so not our own opinion as such, but we use our medical opinion to base our advice on the DWP criteria. And then we send our report back to the DWP for their entitlement decision. So as healthcare professionals, we are not the ones that are making the decision. We are providing advice. It's then the decision maker, an apt name, the decision maker who then provides the entitlement decision. Because in that period between us providing our advice on the report and the decision maker making the decision, there may be other evidence that's been given to the DWP that they need to take into account that we didn't have at the assessment. So maybe there's been another specialist appointment and they've actually been given a clear diagnosis or have been given a different treatment plan, or their condition has deteriorated in some way. That wasn't evidence that we were privy to during the assessment. However, the DWP can take that into account. Okay. Does anyone have any questions on that process at all? Okay. As I said here, this is where the customer's GP comes into play. So provision of medical evidence to assist with the assessment, and the recipient of the medical information obtained in the assessment may need further exploration. All right, I'll hand over to Sue.
You've got a hand up there. I don't know if that's someone trying.
Oh, apologies. Sorry, I was sharing my screen so I couldn't see. Go ahead.
Yeah, what I was going to ask is, it sounds as though evidence could come from a health professional as that application goes in for that first DWP stage. Is that right?
So that, yes, absolutely. So it tends to be that the client has that information already. So like a clinic letter or a GP letter, which they will then hand in with their questionnaire. It's only after we've received that information that if we need more information, we would contact the medical professional.
Because a lot of the forms that I see now, I think many years ago, I could include a report and give that, to the person that I'm working with. But it's, from what I can remember, the most recent ones, it says not to add any more reports in, but you're making me feel I can go back to doing what I was doing before.
When you say report, what sort of report do you mean?
An overview of what that person's function is.
Yeah.
In particular, with those ESA and universal credit claimants. Yeah, it's all around function and work.
Absolutely. Whatever information that you have is invaluable to us because it provides us that information that then we can use in our report writing stage as well. So absolutely, if there's any information that you think will be beneficial or you want to share with us regarding that particular client, then go ahead. Just to also mention, we do get consent from the client, written consent from the client before we ever contact any medical professional that we may need to. So the questionnaire that they fill out, there is a section there that says if we need to contact your GP or another medical professional that you're under, is that okay? And they will sign and date that. If that is not signed and dated, then we cannot contact the GP. And we will not contact the GP as well. But absolutely, if we do contact you and you have any information on their function, that would be fantastic.
Thank you.
And no problem. And Jennifer's asked, do we have a standard template of how professionals should provide letters of support? We don't actually. There is no standard template. The forms that we send out to you from the assessment providers are quite self-explanatory. They are sort of in a template form. So there's areas to fill out: diagnosis, treatment, possible referrals. And then we have a bit of a tick box on the back there talking about different areas of function. So their social interaction, their mobility, their upper limb function, for example. However, if you are just providing a letter to your patient to hand in with their questionnaire, there's no standard template at all. It's whatever you wish to write about the client, and then we'll take a read of that. Hope that answers your question, Jennifer. Okay, so we'll move on.
Thanks very much. Over to me. So I'm covering the slide on insurance. I used to work for an insurer, sit with the claims guys, so I understand it very well. If you have any questions, please do ask, and hopefully I will be able to answer anything. And so the assessment process carried out by insurance assessors is similar in some ways to the assessments that my colleagues have described. However, whereas DWP assessments are looking at someone's ability to work in any capacity or an occupation, when we're looking at insurance claim, the assessment's made against policy criteria. So it depends on the policy really what that looks like. If you take, for an example, an income protection policy, we're asking, does that individual have the capacity to undertake the insured role? So this is looking at whether they can carry out their own or sometimes a suited occupation. So obviously that depends on the policy. There are other policies that we assess against. They can be things like total and permanent disability or for care. And for those, there's set criteria to meet. So it might be things like, can they walk 200 meters? Can they toilet independently? Those are the sort of things that we're looking at. So it's worth remembering that just obviously we have to explain this to people, to claimants, that just because they're signed off by their GP, it doesn't mean that they're necessarily going to meet the definition of the policy in order to get the claim. So when we're looking at someone's capacity, if you like, the assessment is based on function. I think hopefully we've got that message across. So like everyone else, and in order to assess this, we're again collecting a range of evidence, and this generally includes a claim form from the individual. That's similar to my colleagues and how they described it. But though, in my experience, sometimes a claims assessor will go through the form with an individual verbally over the phone. They tend to get better information that way, and also they're sort of building a bit of a relationship. So I think that works really well. Then they'll also get a claim form from the policyholder. Now, sometimes the policyholder may be the individual, but commonly it's their employer who has taken out a group policy. So the policyholder, the employer, will be giving details of the job role, their salary, hours, that sort of thing, details about their absence from work, the employer's understanding of the condition and how they see it preventing the employee from working, and that's often really useful information. It also, these forms ask the employer to describe any reasonable adjustments that may have been considered or discussed or implemented, how that's worked, and also why they haven't been, if they haven't. So that's, sometimes that can be, again, really useful information from the employer. We also have any occupational health reports. They're very useful. They can give a lot of background, understanding the history of the condition, and a bit more medical information, perhaps how it's impacted the employee at work functionally, and also perhaps some recommendations that they've made to support the employee to stay in work. And this is the bit where you GPs, we rely on GPs to provide information. And we usually ask for this to go back some time before the absence, because then we get a clearer history of the condition, its background and the treatment. It's really helpful for the assessor to have copies of any specialist letters or assessments and interventions. And if as a GP you're asked to provide information, remember the assessor is looking for the impact of the condition on function. I know when I get referrals, I sometimes get the GP notes, and as I'm sure you're aware as GPs, sometimes they're absolute huge, massive, great big documents with page after page. So again, it's really helpful to, if possible, to have specific information. In some cases, there's insufficient information from these sources to make a claims decision, or there can be conflicting evidence. So as in the other assessments you've been hearing about, the assessor might reach out to get more specific information, either from the individual or from themselves, the GPs, or a specialist. And again, here they're using specific questions to elicit specific information about the impact of the condition. And sometimes there'll be a request for an independent medical examination. Sort of, it's a bit like a second opinion, really. And medical reports, if there's insufficient information around the individual's function, then a functional capacity assessment may be used. I'll be covering that in the next section, a little bit more about that. I think if you are supporting a patient who's being assessed by an insurer, it's worth understanding that it can take quite a bit of time to integrate and review all this information. As I say, sometimes it's pages and pages, and also considering the detail. And if it involves, it can take longer if it involves getting additional details to enable a decision to be made. And of course, this is where sometimes delays in getting those reports can really delay a decision and the payment of benefit. We often ask the claimants to come and ask their GPs as a sort of shortcut, because especially if they're sort of out of pocket and they're not getting their benefit or a decision made because of a delayed report. So I'm sure as GPs you get inundated with requests for reports, but it's really helpful to get those back as soon as possible. It's often the case that the barriers to return to work aren't medical, and my colleagues have been talking about the biopsychosocial approach. Even if the initial cause of the absence is the reason for them being off, but where there are delays in submitting a claim from an employer, perhaps waiting for the sickness benefit to run out, which is, is 6 months, sometimes they may not get a claim sent in for 6 months. And of course, by then you see some of the sort of illness behaviours, deconditioning, the individual being away from the workplace, losing their routine, perhaps having difficulty sleeping, and additional if you like, functional problems like fatigue, maybe mental health issues. So there could be lots of reasons why they're having difficulty going back to work, and that can act as a barrier. Many of the insurers have either an in-house or an outsourced team of vocational rehab consultants who can support the individuals with returning to work. They're often employed to deliver early intervention, which is where I was saying, instead of waiting for the 6 months, where a claim has been submitted, hopefully it can prevent some of these barriers and the deconditioning from long absences. So I think this point really about the vocational rehab consultants leads nicely onto my next slide, please. That's going to cover more about vocational rehab. So thinking about maybe perhaps clarifying what I mean when I'm talking about vocational rehab, I'll look at the UK Vocational Rehab Association, which defines it as any process that enables people to overcome obstacles to accessing, maintaining or returning to employment or other useful occupation. I'm aware that increasingly there are OTs working within primary care now, delivering VR and writing fit notes. So I don't know, some of you may have come across OTs working in primary care. I know I attended a webinar last week where an OT was describing how she and her colleagues have supported, I think it was 72% of their referrals staying in work. So I think they were employed using the additional roles reimbursement scheme. So there's some really great stuff going on out there in primary care, which is very encouraging. But going back to vocational rehab, the process, if you like, of vocational rehab could be a standalone assessment, like a functional capacity assessment, a vocational or workplace-based assessment, and associated recommendations, or it could be part of a wider programme of intervention, and that could include perhaps development, implementation of graduated return to work plans, perhaps career redirection services, or vocational coaching. But the main focus of vocational rehab is overcoming obstacles to fulfil the vocational or occupational goals. And those goals that we're looking for are meaningful employment, and that could be paid work or perhaps unpaid voluntary roles. So in vocational rehab, we're assessing and identifying those obstacles or potential barriers to working. And they could be things relating to the individual. It could be their physical or psychological, cognitive, sensory, functional limitations, or it could be barriers relating to the work environment. Perhaps it could be the physical or social environment. It could be their actual tasks they have to carry out, or perhaps relationships at work. It could be factors outside of work. Perhaps it could be around the person's beliefs about their condition or issues like childcare or transport. So vocational rehab is helping people to stay in work, to remain in work, if they're experiencing challenges perhaps relating to their performance and managing their health condition. It also helps people to recover in work, using work as a therapeutic tool, perhaps grading their duties or their hours over a certain time period, enabling them to build up and recondition towards their job demands. Or it could be perhaps modifying, changing their job tasks so that it fits their capacity. And vocational rehab helps people to return to work once they've been sick, or perhaps reach work if they haven't entered any paid or voluntary employment, or perhaps want to move on and expand their work options. Next slide, please. I'm going to talk a little bit more about the functional assessment and how it's core to vocational rehab. So to effectively support someone with rehab so they're able to go back to work or perhaps move to a new career, it's essential that we have a really good understanding of their functional abilities and their limitations. We believe an individual's occupational performance is shaped by the interaction between the person, the environment, and their occupation. So when we assess the individual in a functional assessment, we're evaluating the impact of their health condition on their cognitive capabilities, their physical performance, their psychological, social, and sensory capabilities. Like other assessments, we're gathering information. We're looking particularly around the physical, cultural, social, and environment, both at work and at home, and the impact that that has on the individual's performance. Like my colleagues described, our approach is looking at the whole person, looking at that biopsychosocial approach. We're aiming to get a thorough understanding really of the whole picture. And when we're thinking about occupation, we're looking at the groups of tasks that that person's engaged in to do their job. The process of a functional assessment, or what we call a functional capacity evaluation, usually consists of reviewing all the referral information around the medical information as well, including that. And we focus on a face-to-face, it's always face-to-face interview to gather the information about medical situation, their treatment, their work history, the current work demands. We need a lot more than the job description, a really detailed analysis of the role. It's called a job demands analysis, or JDA. We also spend time understanding their current level of function. My colleagues described the typical day. So we're looking like them, we're looking at what they do during the day over the course of a week. We use forms for them to fill in as well, where they can monitor and record what they're actually doing. We look at the history, the good, bad days, the fluctuations in their condition and the impacts on their activity. So we get a really good understanding of the level of activity and the impact that that has on things like the symptoms, the pain and fatigue. Our assessment, these sorts of functional capacity assessments are often around 4 hours. This enables us to extrapolate and identify really what they could do over a day. And during this time, we're looking and observing their sitting and standing tolerances, their pain behaviours, posture, their language, and their signs of fatigue as well. We're looking for. The evaluation then proceeds to testing, very specific testing, and we're looking to obtain baselines for reported pain, how that relates to their behaviour, what they're able to do. So if we're testing for safe maximum physical capacity, we'll keep an eye and check their blood pressure and their heart rate. And then we're testing range of movement, strength, grip and dexterity. and then perhaps more demanding subtests like pushing, pulling, lifting and carrying. And the important thing about this is that the tests are specifically designed, tailored, selected, and looking at that within the individual's role in mind and matching those job demands. So we're trying to look at really objectively what they can do around their job. And if the condition is affecting their cognitive performance, then the assessor can use a series of tests that evaluates the domains like language or executive function, memory, processing speed, perhaps, and concentration and attention. If the psychological function is affected and affects their performance and engagement in work, then would also use a variety of mental health screening tools to identify and evaluate issues. So we use this information gathered from the functional assessment for a number of purposes. We can use it to identify, commonly we use it to identify, can they do their own job? So we're matching that individual's functional capacity against the demands of their job. So are they able to do it? Are they able to do it perhaps modified, if it's modified? Secondly, it enables us to identify alternative appropriate roles if they can't do their existing role, or perhaps if they're new to going into the world of work. We can use it to identify the sort of support and the adaptations and adjustments to enable that person to stay in or go back to work in a sustained way. And our assessment also identifies the rehab needs to improve the function in relation to those specific work tasks. So perhaps where someone's struggling with one particular aspect, we can identify it and then provide appropriate specific rehab. So that could be around referral to a physiotherapist to improve range of movement or strength, perhaps. It could be an OT to provide help with hand function, cognitive deficits. Perhaps it could be counselling, talking therapies, and also specifically to recommend adaptations and adapting equipment, perhaps modifying the task or the environment. And we also use the Access to Work service and liaise with them for funding any equipment that's needed. So we're using our findings also to understand how to adapt their current routine or ways of doing things as well. So we can advise them on how they can better manage their symptoms and at work. So it could be things like taking rest breaks, perhaps changing and alternating, switching tasks to reduce the impact on one area of the body or help to manage cognitive demands. And lastly, it enables us, importantly as well, I should say, enables us to better help employers to understand the challenges for that individual and what's going to help them. Breaking down the functional impact of a health condition helps to make it clearer to a manager so they can better support their employee. So that the manager, for example, if they understand the impact of fatigue on things like perhaps accuracy or attention in meetings, perhaps, or safety issues, they're likely to be more supportive of the recommendations that we might make to accommodating, to address the fatigue. Okay, so I think we have some case studies to share with you, but before we do that, are there any particular questions on what I've covered so far? No? Okay. Do you want me to kick off, or are you going to pick these up?
Yeah, happy to go. Yeah. So this is a case study of which we've got a 25-year-old female who has a history of cervical cancer undergoing chemotherapy. The chemotherapy started 3 months ago with 3 weekly cycles. They've got a long-standing history of depression and anxiety, but are not on any current treatment for their mental health. They are keen to return to work. She attends the clinic alone, she walks at a normal pace, and she's alert and orientated. What are your initial thoughts regarding this patient? So let's get some of your thoughts. What do you think? Yep, somebody's got their hand up. Julie? Or is it Michelle?
Sorry,
Not
yes.
sure.
Yes, Julie, yeah. Sorry, I'll switch my camera on and stop being rude. So I'm an occupational therapist. So hello. My initial thoughts are, what is her work? What are the demands on her? Is there any scope for some sort of cycle with chemo when you have good weeks, bad weeks, and you sort of go through that? So is there scope that she could return to work on a good week? She can return to work, and then either the work lessens or she doesn't have to go to work for a week every 3 weeks. And when she's feeling particularly sick or anything, is there scope for working from home? Yeah, those are my sort of initial thoughts.
Yeah, absolutely. And that's great. And you're certainly thinking about, you know, the functional aspect of what is she actually doing? What is her job? Although she's keen to get back, what does she do? You know, and that's really important. And you're right about the variability of somebody going through chemotherapy. You could have days where you are absolutely exhausted, can't do very much, or there's maybe a week that you feel much better, and potentially although you're keen to return to work, you might be able to return to work.
Yeah. So are they physical demands? Are they sort of mental demands? What, you know, without knowing what her occupation is, it's a bit difficult. And then her home life, what does she need to achieve at home, and how much energy does that take? Yeah.
Absolutely. Anyone else get any other thoughts on the case? No, everyone shy. So also you have to think about the mental health aspect. So at this, she's got long-standing anxiety and depression, okay, but she's not actually on any medication, is she? She's not seeing anyone. She's not on treatment for her mental health. So with that information, you kind of come to an assumption that, you know, it's potentially, is it in remission? Is it not in remission? Is she currently symptomatic of it? We don't really know. She's come to the clinic on her own, so she's able to get out and about, presumably by herself. She's, you know, alert and orientated, so doesn't seem to be any cognitive issues from a mental health point of view or a chemotherapy point of view, based on that information that we have there. However, as you have clearly identified, there is information that is missing and that we need to get a little bit more information about, not only just her conditions, but also her function in day to day.
And it could be her work sustains her mental health.
Absolutely, yeah.
So it could be really, really important for her to return to work, and that might be what keeps her mental health in a positive way.
Absolutely. And that's something that we do need to think about. It is good for people to be at work and have that social interaction with other people, whether it's colleagues, whatever their job role is. That does help people's mental health. But obviously you have to take it on the flip side of that. Sometimes it can be detrimental to their mental health, depending on the demands and what they're doing. So again, although these conditions kind of interlink and potentially appear on the surface as, oh, you know, she's looks to be doing okay. She's coming to the clinic herself. She's keen to get back to work. Now, lots of people may be keen to get back to work, but it might be, you're right, to help their mental health because they like the social interaction with other people. There may be other reasons. Maybe they have to or want to get out of their house for any particular reason.
And it could be if she's, sorry to interrupt you.
No, on you go, yeah.
If she's going to hospital and she's a patient and she's a person with cancer, she may want to go to work to be identified as a young female who's productive, who is a whatever she does, a teacher, teacher assistant, whatever. You know, it gives her a definite identity and gets her a chance to, you know, if she's sitting in a chemo room chatting to other people with cancer, to have colleagues or other connections. I'm sure she's got friends outside of work and the hospital as well, but you know, just to have that thing of being valued by others, and to actually be with people and have an identified role, I think is obviously very positive.
Yeah, absolutely. And given the information that we've got just there and the history that we have, we kind of mentioned on the functional perspective of things, but how do you think this person is functioning, taking into considering her diagnoses, her age, what treatment she's getting at the moment, and the fact she's keen to return to work? Functionally, do we think that she's going to manage? Do you think she'll be struggling? What do we think based on that information that we've got so far?
I'm not sure we can make that judgment because without the missing information.
Absolutely.
But obviously it's whether she's a person that overestimates her own abilities,
yep,
or not. And sometimes what we want isn't always what we're able to do.
Absolutely.
You know, if she lives at home with her parents still, she may not have a big role within a home, but if she runs her own flat or she's got her own partner and young child or whatever, it could be that she has lots of other demands on her time. So yeah, so there's, as I say, quite a lot of missing information as to
absolutely
stuff you could explore in a conversation.
100%. And that's basically what we're trying to establish here, that although it looks like you've got a fair amount of information there, actually there's huge bits of information that's missing to be able to make an appropriate decision based on function just with what we've got. So if we go on to the next slide, we get a little bit more information, and it slightly potentially could change what your thoughts were. So she finished chemotherapy and she had her third cycle of chemotherapy. She stopped working 2 months ago as a barmaid and is now living an extremely sedentary life. She requires assistance from family due to fatigue and is finding it increasingly difficult to maintain any level of independence. She is generally only able to manage day-to-day activities 1 week of the month, but just before her next cycle of chemotherapy. She's always suffered with depression. However, cancer diagnosis has exacerbated this with constant feelings of low mood, lack of motivation, and anxiety leaving the home. She finds even if she does have the energy to wash and dress, her lack of motivation causes her to remain in the same clothes for multiple days. She had to be brought to the appointment by her mother due to her anxiety engaging with others, and she will be collected once the appointment is finished. Her family are struggling financially, and consequently, she's keen to get back to work to feel like she's contributing to the household. So very similar to some of the points that you raised. Although she's recently finished her third cycle of chemotherapy, it's really taken it out of her. She had to stop her work as a barmaid, so we know what kind of work that she does. And she's having quite a lot of difficulty in her day-to-day functioning because of her fatigue from the chemotherapy, and also her mental health. Her mental health has impacted her ability to do day-to-day tasks, her lack of motivation, her low mood, and anxiety leaving the home. Now, as I mentioned before, she walked into their room by herself alone. So that implies that she's able to go places by herself. However, if we don't ask who brought you, how did you get here, etc., etc., well, you wouldn't find out that information that actually it's mum's had to bring her because she's so anxious. She's going to get picked up by our family member at the end. So she's not actually able to travel by herself because of her anxiety. And that's, again, you only find that out if you ask more questions about your functional ability day to day. Difficulty with having low energy, wearing the same clothes multiple days. Is that because of fatigue or is it because of her low mood? again, that's something that we would want to explore in a little bit more detail. And yeah, she was keen to get back to work, but she's only keen to get back to work because her family are struggling financially, not because she's got a keen, eager beaver, I want to get back to my job as a barmaid. It's more because she feels that she wants to contribute to the household, and she's currently unwell at the moment. So is that surprising to anyone, the new information that we find, or that we've found in this particular scenario? It's not really, because when you think about those conditions, although she is 25 years old, she has a long-standing history of mental illness as well. That's been exacerbated by her current diagnosis. Although she's not on any medication for her mental health, clearly from a functional point of view, she is limited, isn't she?
Mm.
Functionally, her day-to-day is affected by her medical conditions.
Suzanne, can I ask something that might be useful to people to know? Is, generally speaking, if you're assessing for a benefit, if they can't travel to work, is travelling part of that? Do you include it? Because I know in a lot of the income protection insurance side, they don't consider that, as for some reason it's not included.
We don't consider travel to work as a specific domain, essentially, but what we take into consideration is, do they require support to travel to places in general, but it's not specifically to work. There's not a criteria that is, if they can't manage, if they couldn't go to work, then there's not a criteria that would put them into an exempt rule or anything like that, and we don't really take that into consideration. It's more, can you go out of your house by yourself? Can you go to familiar places by yourself, or can you go to unfamiliar places by yourself? And that's really the kind of the main points.
So if they could do their job, but they couldn't travel to work, but they couldn't actually travel.
Yeah, so that wouldn't necessarily be, if, you know, because people can work from home, and I think especially with the pandemic, I think that's also proven that, you know, you don't have to get to a place of work because there is the facility to work from home. Obviously, as a barmaid, I don't really think she could work from home unless she had her regulars coming round as she pulls the pints in her house. But yeah, that's not necessarily taken into consideration unless anything's changed, Sophia. No.
No, that's exactly it. Yeah.
So yeah, it is really important that you get that level of detail when you're doing your assessments, and clearly, you know, when you take this particular case into question, okay, you think about chemotherapy. We all know the side effects of chemotherapy, and we all know the fatigue that can take on someone's body. But also, when you look at the evidence from a condition history point of view, particularly the mental health, having no medication and no specialist input, then you automatically, from a condition history point of view, you go, right, okay, you know, if they're not seeing anyone, are they that severe? What's going on with the mental health? If they're not seeing anyone, if they're not on any medication, surely if somebody was severe, they would need to be on medication, seeing the CPN, seeing a psychiatrist. That doesn't necessarily isn't the case. And I think that's why we kind of focus really quite a lot on the functional ability, because it might be that they're too unwell from their mental health point of view to speak to their GP, to then get referred to the CPN, to then get referred to the mental health team, to even then consider starting medication. She's already on chemotherapy. Why would she want to have more medication that potentially has more side effects during chemotherapy as well, and interactions with chemotherapy? So again, we don't take a snippet of the condition history as being, oh, therefore she's not on any medication, doesn't see anyone, therefore it can't be severe. That's not the case at all. We take an overall approach and look at the functional impact and apply that to each individual person. Again, you could have the same person, but actually their typical day might be completely different. They might have stopped work because they were told by their work that they had to stop while they were going through their chemotherapy. They might have been, they might have one day of fatigue out of the month, and actually the rest of the month they're absolutely fine and able to do their day-to-day activities. They may have had a history of anxiety and depression, but actually they've not got any symptoms at all at the moment, and therefore it doesn't impact them. And you know, they may be actually keen to get back to work and actually are able to get back to work, even though it's the same conditions, the same situation, but the function is different. Yeah, Julie.
Just thinking about, has she shared with work that she's going through chemotherapy? You know, because obviously we talked earlier, or you talked earlier about keeping people in their work and retaining their work. So yeah, has she shared that with work, what she's going through, or has she has a lot of sickness and she's actually at risk of losing her job because she's not shared it? So who gives her that support to feel confident to share something so private, really?
Absolutely, there is an element of that, and it's one of those things that's difficult, because obviously you can't force someone to tell their work about their medical conditions at all, and it is really up to themselves. But and again, that's where the kind of benefit system also comes in to support people who are unwell, who are maybe not able to work, who are maybe have been, are on long-term sick or have been made redundant because they're off on they're off work. And that's where the benefit system comes in to support them financially in times of need. But again, also, I'm not sure because I wasn't on the call at that part, but you also get the element where somebody goes to their GP, they say that I've been assessed by occupational health at my work, and they say I can't work because I've got high blood pressure, whatever it is, or mental health problems. Then they go to the occupational health, so they get signed off by their doctor. They go to the occupational health team and for their assessment, and they say, well, my doctor says I can't work, and I need to be off sick because I've got my mental health problems, or I've got my chest pain, whatever the condition is. And then they get into this cycle where they keep going back to the GP, the occupational health, saying the same thing to each of them, and they don't actually, nobody ever breaks that cycle. It's really difficult to break that cycle if one person is saying one thing and one person is saying another, but you don't actually know what they're saying. You're just getting it on a kind of second-hand information, and you can get into that cycle of people becoming sick. And you get that element of sometimes if people are, put on to a fit note from the GP, they then kind of almost sometimes adapt into the sick role as well. And you can get people who adapt into the sick role, then become more sick, and then they're off longer term. And then as a GP, you're kind of signing them off all the time for being unwell. But actually, they weren't that unwell when you first signed them off, but they've become more unwell because they've been off work and they've got no social interaction, or they've not been able to get back to work, and then it's more difficult for them to get back into work as well. So again, it's always a fine line of trying to get people back into work, to stay in work, or not be put on the sick for a fit note to begin with, and that can be very, very difficult. And I know that as a GP myself, sometimes I have put people on a fit note, and then you would assess them regularly. They then go to occupational health. They can't do their occupation because they're off sick for whatever reason, say it's high blood pressure, and they have to be off work because of high blood pressure. They're getting their medications titrated up, etc., etc. And then it almost creates their anxiety with their high blood pressure, because they come in, they get their assessment done, they get their blood pressure checked, it's sky high because they've come in to see the doctor about the high blood pressure, and it's like a vicious cycle almost. And I think that can be quite hard. So were you going to say something there?
I was just going to, I did touch on that, actually, talking about being deconditioned and people's beliefs and it's and the time away from work. I think, I don't know, I was going to ask Julie if she's signing fit notes and involved in there's an AHP report as well. I think it's been widened who can sign the fit notes now, hasn't it?
I do work in primary care. I'm in one of the R's roles, and one of my colleagues is also on the call, I know, hiding away there, Abby. But I haven't been asked to sign fit notes. I know there's a lot about us doing that, but I work in health inequalities, So I do work with a lot of people on benefits and a lot of people off sick, long-term sick, but maybe off sick and do receive PIP or universal credit, and the stress involved with completing those forms for some people I work with, like you say, people with chronic schizophrenia, and how stressed they get even though they've got a carer that completes the form for them. But the actual anxiety and, you know, when people who've applied for PIP, had it declined, appealed, gone to tribunal, now going to the ombudsman, you know, and I've said, yes, please include my report, and I might have done letters of support. But it is really, really challenging out there as to, there are genuine people in need out there that are being declined the benefits, and then there's other people I see on benefits that possibly could, with support, return to work, with the right support and encouragement. So yeah.
And there are, as well as fit notes, there are AHP reports which can be used as well, which are like fuller, they're like a longer fit note with advice.
No, I haven't seen those.
Oh, okay.
That's interesting.
Yeah, you can get them off the, I think they're on the Royal College of OT site.
Okay, I'll have a look for those. Thank you.
I can find a link. There's also a link of, I think they've got .gov. It's on there as well. They're on there. Yeah.
Can I just say about one, sorry to digress and take over the call, everybody. Can I just say about a DVLA lady I supported? She'd had a stroke and had some visual problems, but ophthalmology had actually said that she had the visual acuity to be assessed. She'd given up her own license, and the GP didn't want to sign the form because he thought the form was saying that she was fit to drive. And when I explored it all, the form was saying fitness to be assessed. So I managed to persuade the GP to sign the form off, and the DVLA immediately came back and said no. So I contacted them through their professional email, and within about another day or so, I had an email back from a lady to say, because I emailed saying, well, this is all we're asking for. And I had an email back from a professional at the DVLA saying, I've reviewed the case and I'm prepared to give this lady a provisional driving license again for 3 months for her to get assessed at an assessment centre. So the system does work. It just takes a little bit of time.
Certainly, I'm not entirely sure with regards to DVLA because I don't work in the DVLA. But certainly, I think the process can be quite long for some people, not just for DVLA, for any of the benefits. It isn't a quick decision. It's a lot of thought, a lot of clinical and critical analysis of all the medical evidence, all the observed evidence, the examination findings. So it does take a bit of time for all these decisions to be made, because we're having to use clinical knowledge and the evidence that we've got in front of us. And sometimes it's not easy to get the evidence, and sometimes the decisions take longer because we need to go out to get more evidence, particularly in some of the benefits assessments. It might be we get, you do your face-to-face assessment, but we still might not be able to make a decision, and you have to go out for further evidence on top of that. And that again does take its time, and it's not a quick fix with certain situations. So I can understand how it can be quite frustrating for people waiting on outcomes for things. Do we have time to do the last?
Yeah, we've got a reminder to remind people to complete the feedback form. We were asked to remind people to do that. It's a link in the chat. It would be great to get that as well. I guess we could have a quick look at it if you want to then.
So this is just another case, again, 59-year-old male, relapsing remitting MS, 3-month reviews by the MS nurse, prescribed appropriate disease-modifying medication, recently commenced on a course of steroids, obviously for the recent relapse, no longer able to work or leave home owing to condition symptoms, came into clinic, pushed in the wheelchair by partner, evident signs of fatigue, pain and audible groans. History shows long-standing relapsing remitting MS with previous pacing therapies and fatigue management courses. Again, what are your initial thoughts on this particular case? Anyone? Again, this is about an element of variability as well, isn't there? Relapsing and remitting MS is a variable condition. They're on quite extensive medication, your disease-modifying medications. They're getting 3-monthly reviews. That they're currently in a wheelchair with evident fatigue, pain. We've also, it says, why might he have found his ability to work and leave the home to be impaired? So what do you think would affect that? No. Well, it could be he lives up 5 flights of stairs and is unable to get out and do the stairs. He may have a full left-sided weakness and is unable to support himself. He's in a wheelchair at the moment, but does that mean that he maybe needs assistance downstairs? He's not able to work. Where is his work? What does he do? What's his job role? All these kind of things. Again, we would need to find out. Very similar to the previous case, as we just need more information about the conditions. Should we move on to the next slide? So again, he's currently experiencing a relapse of his MS. Last relapse was in 2018, and they generally last a matter of weeks to a month. Commenced steroids due to the relapse. However, prior to this, was managing with utilising own pacing and no other medications. He owns his own construction company and is extremely hands-on builder. He's been off sick for the last 3 weeks due to the relapse. In his spare time, he likes to socialise with friends, playing golf and goes hiking on holidays. He cannot leave the home at present as he does not have a wheelchair access and struggles to walk with an aid due to lower limb weakness and fatigue. So very much similar to what we were saying. He has found that due to his relapse, he has lost work in the last few weeks and wants to know about what support he can have. So again, if it wasn't for the relapse, his function is different from what his function is currently when he's having a relapse. And again, that's why it's really important to get the variability and ask about function. And obviously the fatigue and how fatigue affects your ability to function as well. And the variability of that. Good days, bad days, average days, better than average days. We need to get all that information. Grand. So these are just the reflection points. So generally, can you think of a patient in the last 7 days whereby their problems or functions do not seem consistent with the underlying diagnosis? Regarding the above cases, what were the challenges in terms of the consultation and management? These are all things for you to think about and to write about. How confident are you at being able to assess a client's functional ability resulting from their illness, and how relevant do you feel this is in your role? Now, if I was asked this when I did GP, I probably would have thought, wow, actually function is a really big part of my consultation, and I really should have asked a lot more about it when I was a GP, because I think if I'd asked a little bit more about someone's function, I would be able to have more of an understanding of how their conditions affect their day-to-day life, and potentially would have been able to put things in place that may have supported them better than me giving them, say for instance, paracetamol, cocodamol, treatment-wise. But if I'd asked about function, it might have helped a little bit more. And maybe supporting them with getting an occupational health assessment at home. These were things that only kind of came up when you felt it was really needed. But actually, I never really asked anybody, what is your function? which I think would be, worthwhile doing now. Again, what use do you make of the biopsychosocial model of illness in your daily practice? And what is your experience or perception of your interaction or contribution regarding disability assessment medicine? And how can we help in providing information related to functional assessments? That's basically the reflections we want you to think about. And if you've got any feedback, that would be grand. Just let us know. Any other questions or comments? Oh, well, thank you so much. It was a pleasure chatting to you.
Thank you very, very much. And hopefully, if it's okay with you to share those slides, if you agree to that, I'll happily share the slides after.
Okay. I'll send out the AHP report link as well with the slides. I'll get that to you, Lily.
Brilliant. Thank you, everybody.
Thank you very much.
Thank you, everybody.
Thank you.
Bye.